Hello, everybody. This is the completion of the review recording for the second exam. So, as we speak, I covered the cardiac aspect. This is the blood aspect. So, go back and look at the original PowerPoint and the description and listen to it. We separate blood by centrifugation. So, the lightest portions go on top, that's the plasma. The heaviest on the bottom, those are the red cells that pack together. And in between is that buffy coat, white cells and platelets. So that's something that you need to recall. The role of each of the plasma proteins is very important. Fibrinogen is interestingly because that's what makes blood a connective tissue, because we have cells. The fact that it's a liquid media isn't by designation having to be solid. So the ground substance effectively is liquid. The fibers are dissolved. That's fibrinogen. They're only about 4% of the total protein. Uh, Fibrin is what fibrinogen becomes when it's activated by the clotting cascade. That's the whole ball game with the clotting cascade. On the other hand, globulins play an important role. Part of them are immunoglobulins. We're going to deal with that in the immune system. They're called gamma globulins generically. Alpha and beta globulins are transport proteins, particularly for fats and related substances. Sort of the way we move around when you hear about lipoproteins and fats that circulate. Some people have hereditary deficits in them. And then lastly, and as important as any of them, is the one that's the most abundant, that has about 60% of the proteins. And it's 36 for globulins and 4 for fibrinogen. Is albumin. Albumin is sort of a generic term for a variety of proteins, I think would be a fair way to describe it. And albumin basically, other than it does provide carrying for a lot of substances that are not readily soluble in the plasma, but are not necessarily in that category of lipoproteins. But really what it does a lot of is that colloid osmotic pressure. It's a colloid. Proteins hold water, and that plays such a tremendously important role. And we look at that when we're going to look at filtration in the kidney. We're going to look at cellular respiration when we get to basically the respiration in the sort of at the capillary level. Those are really important factors that are involved. We look at all the white blood cells. It's easy. Never let monkeys eat bananas. It's one of the few one of the few little mnemonics that actually work for basis now. Neutrophils are the most abundant, depending on the author, 50 to 70%. Lymphocytes, 20 to 40%. So that's the never let. Monkeys is monocytes. Monocytes are 3 to 10% on average, I would dare say. And then eosinophils, 1 to 5%, and basophils, usually less than 1%. That's what the acronym, those are the 5 major categories of white blood cells. This is the chapter where we talk about this. And again, we revisited an immune system. And interestingly, in the bloodstream, that's what they are. But when they leave the bloodstream, monocytes become macrophages, and basophils typically morph into mast cells. Neutrophils, lymphocytes, and eosinophils kind of stay the same. Neutrophils are kind of neat because they have a multi-lobe nucleus between. So the nucleus basically is kind of folded or twisted, and it looks like it has anywhere from 3 to 6 lobes. The other author says 2 to 5. I think that's incorrect. 3 to 6 has been pretty much standard. Okay, and certainly are the most numerous, and they're the bacteria slayers. They're the ones that go after bacterial infections, and typically we see them as being one of the first ones on the scene for anything. Okay, and when they ramp up to higher numbers, then you're pretty much looking at a bacterial infection. So I think that's really important. Now, there are 2 categories: the neutrophils, the eosinophils, and the basophils are what we call granulocytes. They have granules that we can readily see when they are stained. We categorize them based on their staining. Neutral staining of the granules that are visible is neutrophils. It's sort of they call it a lilac color. It's neither red nor blue. The red ones are eosinophils. The blue ones are basophils. Easy to remember for blue for basophils. And now, on the other hand, the lymphocytes and monocytes, they have granules. They just don't stain. So they appear to be non-granulated, or some people call them agranulocytes. Not really, it's sort of a misnomer, it's really not the same. Monocytes have, and they both have pale blue cytoplasm. The difference is lymphocytes, the nucleus appears to be a scant amount of cytoplasm. The nucleus is sort of disproportionately large microscopically, and you see little bits of cytoplasm, where the monocyte is by far and away the largest of all these cells. And the monocyte has a nucleus that it's either got like a little, sort of like a U shape or a kidney shape. It's got sort of an indentation. And it's large. That's really what gives it away. And then the fact that, you can see the cytoplasm. They're called mononuclear forms. That's where we get the idea of mononucleosis. We used to think it was just monocytes. It affects both. So that's really important. And of course, the other formed element that we see, in addition to the red cells and the white blood cells, and remember the white blood cells are the only true cells because they have a nucleus. The red blood cells shed their nucleus, are the platelets. That's the other form. And the platelets are little fragments. There's this giant thing called a mega, for giant karyocyte. And basically, that's sort of all it keeps doing is dividing and dividing, but it never really. It got big, the cytoplasm and the nucleus keep dividing, but it never divides in the sense of the cell itself. So little fragments kind of push off, almost as they went through like a sieve or like a colander, you know. And you get these little cellular fragments of membrane containing granules. Those are platelets. And I mean, numeric platelets are much smaller, but numerically there's a large amount. Remember, red blood cells, 1,000 times more of them proportionally than white blood cells. And compared to white blood cells, there's a lot more platelets, but the platelets are so tiny. It's not so much as a tangible number. You see platelets are just like little teeny tiny fragments under the microscope. Red cells, you just see a mass of, and the occasional white cell. So as we move on, so all of those are important things. So in general, if you want to look at a lymphocyte, it's typically larger than a red cell. It's not as big as a monocyte. The lymphocytes that you see on a peripheral blood smear, if you're looking at a picture under the microscope that's in all the textbooks, or you look at them yourself in lab, effectively, that's probably a T cell. It might be a B cell. Okay? But typically the ones we see in the smears are typically T cells. But you can't identify it from, is what I'm saying. So that's part of it. And the nucleus looks like it fills the entire cell. I mean, that's really sort of the giveaway about that. Down the road, when you get into immunology, you're going to see that the B cells and T cells, which look the same, once the B cells become activated, they change and they form something called a plasma cell, which looks slightly different. But you really, for this class, it's not critical to look at the microscopic differences whatsoever. We learn about the functional differences when we do immunology. And lymphocytes, where bacteria are the big player, and the bigger part where neutrophils are the big player in bacterial infection, lymphocytes are the big player in viral infections. When they're elevated, think of a viral infection. Maybe it was COVID. Maybe it was the flu. And think when they're lowered, now you think big problems. Because when lymphocytes start to go down, then that's an immunological deficit. So there's some perhaps immunological disease, or maybe this person is HIV positive and trending toward AIDS. So those are just some of the things you typically look at. Red blood cells are interesting because most cells get bigger as they mature. Red blood cells get smaller. So a sign of an immature red blood cell sometimes is it's too large. Typically that's associated with things like B12 and folic acid. If it's associated with B12, it's got a famous name. It's called pernicious anemia. And that's a name you should remember as well. So how do we tell it's maturing? It begins to, it finally sheds its nucleus. And at the very last, it sheds any remnants of any internal structures, particularly rough and smooth endoplasmic reticulum. Okay, and the way we describe those cells, which we do see in the bloodstream, are called reticulocytes. They are red blood cells that have lost their nucleus but still have some visible remnants measurable remnants of the endoplasmic reticulum, hence the name reticulocytes. It's normal to have about 1% of those in your bloodstream. They're a very useful measure of anemia because what happens, if we can kind of get an idea what's going on in the bone marrow, where all the blood cells are produced. Pardon me. That 1% number is the norm. So 99% of those are mature, because remember, that's a sign of immaturity. 1% are not quite ready. That's normal. If you're pushing out if that number is low, okay, then it's almost as though we're pushing out an excessive, overly mature red cells, and you don't see that often. And on the other hand, if that number is high, you're pushing out a lot of immature red cells. So immature really is significant. It means maybe there's something in the bone marrow, like a tumor, that's pushing things out because there's no space. And maybe there's a fault in red blood cell development if they're overly mature and they're just not being able to get out. And these are kinds of things that are really a blood specialist, a hematologist, who's also a cancer specialist, oncologist, would look at. Red blood cells are unique because of that biconcave disc. They're elegantly designed to do one job, and that's carry oxygen. They are filled with hemoglobin molecules, about quarter of a billion, about 250 million in each red blood cell, and they each have 4 places where oxygen can lay on. There's 4 heme units, and the heme units is where the oxygen sits, or is adherent. Adherent's the wrong term, but bonds to, at least reversibly, until it delivers oxygen to the tissues. So that means each red blood cell has the carrying capacity of 1 billion molecules of oxygen. It's immense. So it's really, you should know the structure of hemoglobin. It's got 4 globin chains, 2 alphas and betas. They each surround one of those heme units. When we break apart a red cell, we can recycle the globin, just amino acids and proteins, and we can break those apart and reform them as we need them. The iron, we have a pretty good ability to recycle the iron. It's Fe+2. That's called ferrous. If you don't remember your chemistry, but it's not a big deal. It's that heme unit, which is an interesting molecule that the iron sits in the middle, and that little that iron ion, I know it's a tongue twister. And what's interesting about that is we can't recycle that, so we have to get rid of it. And your liver does a pretty effective job. Your spleen can break down a fair amount of it, but your liver really does the processing, and it creates something called bilirubin. And we have to excrete that. And we typically excrete it in the urine and the feces. It actually gives the color to the urine and the feces. Okay. And when it backs up, one of the things, if there's a blockage, it damage to the liver, gallstones in the gallbladder, damage at the bile duct where things come in. So it's secreted in something called bile, which actually helps us digest fats, but also gets rid of this waste product, and it's produced by the liver. And anytime there's a backup, again, ultimately it's a plumbing problem, it backs up into the bloodstream, and you get this yellowish appearance where you in the whites of your eyes, in your lips, in your fingers, and areas where we're relying on pigmentation from actually the blood itself, the hemoglobin in the blood, to provide a certain obvious pigmentation. So you get this yellowish cast. They call it yellow jaundice. Have you ever seen somebody with bad liver disease or somebody who's awaiting a transplant? You can't miss it. So it's really another one of these significant findings that you should be familiar with. I lost my place for a second. I'll keep going. Trying to do this dictation. The lighting is not great. So let's see. So when we get down the road and we start thinking about things like clotting, okay, spent a fair amount of time on that. There are 2 approaches to clotting. There's the intrinsic and the extrinsic. There are 2 we call them pathways. They're both active. They're there all the time. They're not active all the time, but they're always ready to be activated. The pathway we use all of the time, and it works comparatively slowly, is called the intrinsic pathway. It has multiple steps. It's really roadway repair. If you want to think of the blood vessels as miles upon miles. I mean, lots of miles, thousands and thousands of miles of roadways in your body. They get damaged like anything else. They form little ruts and irregularities. Collagen is exposed. Platelets adhere to it, and they start a repair process. It's called the intrinsic pathway. Okay. So one that's activated occasionally, but works very, very quickly because it's generally associated, or not generally, it's associated with damage to the tissue. Okay. It's the extrinsic pathway. So that means cells are damaged, whether external or internal. And the potential for that means there could be a lot of blood loss. So that's a very rapid pathway. So, and hopefully we don't have to use it terribly often. So what is released by damaged cells, and it's called the extrinsic pathway because it's not in the bloodstream. All the factors in the intrinsic pathway are already in the bloodstream, they're in the platelets. The extrinsic pathway means that there's a factor or factors that cannot initiate the clotting. It's called tissue factor. In the old days, we used to call it tissue thromboplastin. And so that's really the unique feature about that system. That's the distinction between intrinsic and extrinsic. And intrinsic we use frequently, it takes a long time. Extrinsic we use rarely, but it works very quickly. Those are the difference between the two of them. They basically have the same roadway. Intrinsic has multiple steps. The extrinsic has very few steps, and their road takes them to factor 10. There are people with genetic deficiencies in clotting. Okay, the famous name is called hemophilia. It's hereditary. It's also sex-linked. Not that that's a big deal for us. Hemophilia A, the most common type, involves factor 8. There's hemophilia B, which involves factor 9, which is not necessarily as frequent. When we rely on clotting, it's the easiest thing in the world. We use vitamin K. K for clotting, just think of it this way. On my kitchen counter, I just saw vitamin D3 supplements and with additional vitamin K. I can't tell you how many people I know take those same supplements because they help as folks get older. Okay. The vitamin D is very, very useful for a lot of problems, and we will have and we'll continue to talk about that. And I think you should have higher levels. And the vitamin K, make sure that your clotting system is working properly, because sometimes the vitamin D can make your blood a little less likely to clot. That's some of the problems with some certain fat soluble things. So it's neat that they put them together. So I need to understand all those types of things that we have discussed, where the fibrinage is in, the fact that it's dissolved, the relationship mast cells and basophils, the relationship of monocytes and macrophages, the things of the granules, the role the platelets play in clotting. All of those things are very, very important to continue to remember. Oh, by the way, that intrinsic system, when those roadways and the tiny blood vessels, and typically we see this more in arterioles than because we have more of those, with the exception of capillaries, which really don't have the defect because it's about collagen. When those roadways get little defects, collagen can be exposed. Capillaries really are just cells. They have maybe they have a certain amount of protein surrounding them as a basement membrane, but we really don't see the clotting per se in that. We really see it more in arterioles, and particularly the small ones. And what will happen is collagen in the underlayer under that endothelial lining will be exposed. Okay? And understand when these roadways effectively temporarily clot, those clots would stay there theoretically indefinitely. So immediately we start to, within 2 or 3 days, activate a parallel pathway to the clotting cascade to start to break up clots. It's called plasminogen to plasmin. What activates it is called TPA, tissue plasminogen activator. We now make that genetically. And if we get a patient who has a stroke that's starting or a heart attack that's starting, in the emergency room, we can insert a catheter in the appropriate area and deliver it either to the heart or deliver it up toward the brain and inject through this catheter effectively a clot buster. And that's what TPA is. So it's really very interesting. So tissue plasminogen activator, it's a mouthful, so we say TPA. And again, And what it does is it's the catalyst to turn the clot busting protein in its precursor form, plasminogen, to the clot buster plasmid, hence the name tissue plasminogen activator. Okay, and let's see. I think we covered everything else. Oh, blood types. I knew I forgot something. We remember the different. There's a couple of basic questions on this. Remember, positives are much more numerous than negatives. So just the predominant type are positives. 80 to 85% of us have positive for the Rh factor, because that's standard Mendelian genetics, and so it's 3-to-1 normally, since that's dominant, standard dominant recessive. And on top of that, okay, people who are positive are more likely to have children with other people who are positive. That's why it's more than 3-to-1. The other hand, that unique system with multiple alleles and codominance is the ABO part of the system. So remember, if you have AB blood, okay, so if you have type AB blood, okay, you don't make antibodies. If you have type O blood, you don't have any antigens. AB blood has antigens for A and antigens for B, and they're the important part that are on the surface of the red cell, and they don't make any antibodies. And this is all explained thoroughly on the PowerPoint, and we discussed it in a lecture. O doesn't have any surface antigens, but makes antibodies. That's why for years O is referred to as the, quote, universal donor. But the reality is, if it's O positive, it's not, it's O negative. The same way the universal recipient used to be, say, well, it's AB blood, but it actually has to be, actually AB blood works fairly efficiently, but it would be best if it was AB positive, because then you have surface antigens to A, to B, and to the Rh factor. AB neg would be a problem if somebody gave AB positive too, because that positive would trigger some type of reaction, maybe not as severe as an A and B, because remember, type A has A antigens and makes antibodies to B. Type B has B antigens, makes antibodies to A. That's the mix-up. Okay. So that's really what you know about transfusions. We typically use, when we siphon off the blood, we typically use packed red cells because they're less likely to be associated with hepatitis C or HIV. The blood banks have done a wonderful job screening since 1987. Prior to that, there were some big problems that were there, particularly once we began to see the era of HIV and hepatitis C. So after 87, they made a lot of changes in that. Blood bank blood is statistically safer than directed donation. Remember, I'm going to have my dad or my mom, or they have the same blood type, donate to me. Statistically, it's not as safe having a relative donate as blood from the blood bank, but the safest blood is your own. And we call that autologous or self blood donations. And then when we have elective procedures that you may need to have blood on board, you donate a couple of units, and over intervals, they keep it on board. And it's there when you're having that hip replaced or that shoulder replaced, because typically there's a fair amount of bleeding and you never know. And I think that's everything we have to talk about. And thank you very much. And we'll see everybody in lecture and for the exam, which we're having on Friday, the 14th. Thank you. Bye-bye.